Asthma is a chronic inflammatory disease of the lungs, characterized by reversible airflow obstruction due to hyperresponsiveness of the airways to different stimuli. This animation will illustrate the pathophysiology of asthma, as well as the mechanism of important pharmacological agents used in its treatment. We will begin with a brief review of the respiratory system's normal anatomy. The respiratory pathway begins in the nasal cavity and continues to the pharynx, the trachea, bronchi, bronchioles, and finally the alveoli, which are surrounded by capillary beds and are the site of gas exchange. Inspired air can contain allergens such as pollen, animal dander, and dust mites, which are antigens capable of triggering type 1 hypersensitivity in atopic individuals. Let's start by taking a look at the body's reaction to an allergen after initial exposure. When inhaled for the first time, allergens pass through the upper airways, the trachea, bronchi, and ultimately reach the bronchioles. Let's take a closer look within the bronchioles. The allergen is phagocytosed by an antigen-presenting cell, such as dendritic cells. Peptides processed from the allergen bind to class II major histocompatibility complex molecules, or class II MHC. The class II MHC peptide complex then travels to the surface of the cell, where the peptide is presented to T helper cells. Now, let's focus on the interaction of these two cells. Class II MHC on the antigen-presenting cell binds to the T cell receptor, or TCR, on the T helper cell. This is followed by CD4 binding to MHC2. Next, B7 binds to CD28 on T helper cells. These bindings serve as the first signal for T helper cell activation. After this interaction, antigen-presenting cells secrete cytokines, such as interleukin-4, which induce the proliferation and differentiation of T helper cells into T helper 2 cells. These CD4 positive T helper 2 cells will activate only those B cells that recognize the same antigens as they do. Cytokines such as interleukin-4 and interleukin-13 secreted by T helper 2 cells will activate B cells. Leading to their proliferation and differentiation into immunoglobulin E secreting plasma cells. Secreted IgE binds to specific Fc receptors on the surface of mast cells and other cells involved in the acute inflammatory response. At this point, the IgE-coated cells have become sensitized to the allergen. Now, when future exposure occurs, the same allergen will reach the bronchioles. Where it binds to the IgE molecules on the surface of the sensitized mast cells. This binding activates mast cells, leading to degranulation and the release of powerful chemical mediators such as histamine, cytokines, leukotrienes, and prostaglandins. These mediators cause different systemic and local effects. In the circulatory system, histamine binds to its receptors on the endothelium, leading to vasodilation and increased vascular permeability. This causes fluid extravasation into the surrounding tissue, resulting in edema. Let's now take a closer look at the bronchiole. Histamine and other mediators, such as leukotrienes and prostaglandins, cause massive local inflammation, smooth muscle contraction, and induce mucus production. This leads to narrowing of the distal airways, which results in dyspnea, coughing, and wheezing. We will now review the mechanism of action of several pharmacological agents used in the treatment of asthma, such as beta-2 adrenergic receptor agonists, corticosteroids, and leukotriene modifiers. We'll start by zooming in on a cross-section of the bronchiole. Albuterol is a short-acting beta-2 adrenergic receptor agonist, used for immediate relief of bronchospasm. When binding to its receptors on airway smooth muscles, it causes bronchodilation, subsequently increasing airflow to the lungs. Glucocorticoids can be inhaled or taken systemically, depending on the severity of asthma. When glucocorticoids bind to their receptors, it suppresses airway inflammation by inhibiting prostaglandin and leukotriene production. Glucocorticoids are highly effective in long-term control of asthma by reducing vascular permeability and edema, as well as mucus production. Zafirlocast is a leukotriene modifier that acts as a receptor antagonist. This inhibits the action of cystenyl leukotrienes within airways, thus reducing constriction of the airway, buildup of mucus in the lungs, and inflammation of the breathing passages.